Good morning, everyone. Thank you for joining Senate Bill 460 Workgroup. My name is Corey Boone. I'm Special Deputy, and the purpose of today's meeting is to discuss the current programs that assist patients and their families with services described in the CHAP bill and the gaps that can be the gaps that could be filled by the establishment of the bill. So I will introduce the members of the Maryland Insurance Administration. We have Commissioner Bahrain.
Good morning.
David Cooney, Associate Commissioner of Life and Health. Mary Quay, Associate Commissioner of Market Regulation and Professional Licensing.
Good morning.
We have Van Dorsey, Principal Counsel.
Morning.
And Craig I, our Communications Director.
Morning, you're welcome.
So I would like everyone to introduce themselves, starting with Senator Augustine.
Morning, my name is State Senator Malcolm Augustine, represent Prince George's County, sit on the Finance Committee. I'm happy to be here. Thank you, and was a sponsor of this piece of legislation. Thank you.
Do we have Delegate Lewis on? I think so. Ms. Rifkin, can you start it and everyone follows?
Sure. Good morning, everybody. Debbie Rivkin, Care First, Blue Cross Blue Shield.
I'm Ann Seacott with Public Policy Partners, representing NCADD Maryland.
I'm Ellen Weber, Legal Action Center. Also, we convene the Maryland Parity Coalition.
Dan Martin, Mental Health Association of Maryland.
I'm Neil Karkanis here on behalf of the League of Life and Health Insurers.
Pat O'Connor, Deputy Director of the Health Education Advocacy Unit, the Consumer Protection Division, the Office of the Attorney General.
All right, do we have anyone on the phone?
There's a 301. There's a 301 number there.
Hey, Commissioner, it's Joe Wynn at United Health Group.
All right. Thank you all. We will pass it along to Mary Quay, who's going to give a brief summary of the findings.
Thank you, Corey. As Corey said, I am Mary Quay. I'm the Associate Commissioner for Market Regulation and Professional Licensing at the MIA. At our prior meeting, the MIA asked whether there was agreement that the navigator function described in SB 460 would fill a gap that currently exists. We learned that there are a number of organizations that help patients and their families find care, and not everyone thought that there was a gap. Working group members sent the MIA information on organizations that currently provide services, including connecting patients to care, and the MIA conducted further research. I would like to walk through the results of that research at a high level. I want to leave plenty of time for discussion, so this will be a summary. Statewide, we have 211. Some counties list this as their crisis response number. We heard from 211 at the last meeting, and this is a valuable resource. There is also 988, which operates at a national level as the National Suicide Prevention Lifeline and the Veterans Crisis Line. And there is also the Crisis Text Line that is national. Some counties have their own crisis response systems and may be able to provide referrals for help in other situations, not only in a crisis. These include programs in Anne Arundel County, which is well known now for their Safe Stations program, Baltimore City, Baltimore County, Calvert County, Carroll County, Charles County. Eastern Shore counties operate a joint line. Frederick County, Garrett County, Harford County, Howard County, and Montgomery County. Some counties offer programs to assist specific groups, such as children and adolescents, or to provide culturally appropriate mental health assistance for specific ethnic groups. County health departments may also offer services to assist with behavioral health treatment. And I will use the term behavioral health to encompass mental health and substance use disorders. In Western Maryland, the University of Pittsburgh Medical Center has Path to Help with an online search tool for behavioral health services. UPMC also provides a crisis intervention line. Prince George's County uses 211 as its crisis number, but the Prince George's Healthcare Alliance can provide care coordination and advocacy services for Prince George's County residents with high need and high utilization of resources. Voices of Hope helps residents of Cecil and Harford counties helps them access healthcare or behavioral health treatment. Howard County has a behavioral health navigator. County programs may be under the county government or may be formed as 501c3 entities. Funding for crisis services is generally a mix of federal, state, and county dollars. Other services may be offered through nonprofit organizations. Services are generally limited to county residents. There are connector entities that assist with enrollment in health plan coverage through the exchange, including both individual health insurance and Medicaid coverage. Some nonprofit organizations provide assistance in locating mental health services or provide services directly as a part of their mission. These services are generally limited to the population the nonprofit serves. Examples of this are the Alzheimer's Association and Johns Hopkins, which have programs to help link caregivers to resources to help deal with stress. The NCAA has mental health resources for college athletes. There are organizations that deal specifically with substance use disorder or providing support to families, not to the patient. And the Maryland Network Against Domestic Violence can offer referrals for assistance and free counseling to people in need of their services. National organizations operate databases that can be used by members of the public to locate resources. FindTreatment.gov is operated by SAMHSA. MentalHealth.gov has a variety of information, including SAMHSA's treatment services locator. The American Academy of Child and Adolescent Psychiatry and the Maryland Psychiatric Society also have databases to find a psychiatrist. There are many organizations offering some help to different populations in need of mental health or substance use disorder services. It appears that there are still gaps that could be filled by a statewide program to provide and follow up on referrals, assist with case management through different levels of care, and work with insurance coverage to verify that providers are in network and to determine if authorization is required, or the program could work with the insurer's case management program. However, it is up to the work group to decide whether this is an area that is adequately addressed by current programs or if a new program is needed. The MIA can continue to research programs offered by other state agencies, but we need to hear what the work group is interested in. We want to hear from everyone, so please keep your remarks concise and to the point, and it is helpful if you can raise your hand to speak. We do have an hour for this meeting, and we want to allow other interested parties an opportunity to speak at the end. So thank you, Corey.
Thank you, Mary. So we will open it up for discussion. Thank you, Delegate Collison, for joining. Delegate Collison and Senator Augustine, would you like to open up with any comments or thoughts?
Thank you, Corey. I would actually like to, first of all, thank the MIA team for its work in gathering all this information. This is exactly the kind of thing that I was looking for when we talked the last time we met. And, you know, it's, and I think Mary's summary, both what you sent in the email plus what she just told us about, is a great summary of the wide range of services that are out there. But I would agree that we need a central coordination point. And I think that the question will come in for me is where that coordination sits in the infrastructure of the state. So I'm interested in hearing what others are thinking and feeling about that. And I think it's going to be, that's going to be the heart of our discussion if others agree that this kind of central coordination is needed. And thank you, Corey, for letting me speak.
Of course. Thank you, Delegate Collison. Any discussion? None.
Hey, Corey.
Yes, Ms. Weber. Oh, okay.
Sorry.
Ms. Weber.
Okay.
Thank you. Thanks so much. And again, thank you to the MIA for organizing that very helpful list of entities. There are 2 points I wanted to make initially, if I could. The first point is that I was a bit confused by the characterization of the activity of case management. Case management, in my way of thinking, is in care coordination. That, in my way of thinking, is a therapeutic model. That is individuals working with their clinicians, identifying what services they need to go to, and then to manage their movement across levels of care. The CHAP program that was proposed in SB 460 was not designed to do that type of therapeutic care coordination. It's designed in order to help individuals identify the services, the mental health and substance use services that are covered under their insurance, and to gain access to those insurance mandated or insurance covered benefits by all different types of payers. So it is the entity that has a laser focus on the insurance and the coverage under insurance and access under insurance, and to do problem solving when there are insurance barriers, which we have identified exist, and then to represent and help clients all along that continuum, including filing complaints. And so that element of it is that was described in the email was not something that care coordination is essential, but it was not one of the elements of those activities. And the other point that I wanted to identify is there is a focus in these activities, as we could all tell, on the front end activities, identifying where the resources are through hotlines, crisis services that link individuals to care, and the connector entities that help individuals get enrolled in insurance. Those back end services, which there is still an essential need for, were really clearly not existing in this state. Health Education and Advocacy Unit, as we've all discussed, provides those services. It has not penetrated into the community of individuals with mental health and substance use disorders. But there are no other entities that have been identified that deliver that type of more intensive navigation of your insurance, problem solving when you face barriers, and representing individuals with a targeted focus on mental health and substance use disorder concerns in internal grievances, external appeals, and other types of representation. So, and again, across all the various kinds of payers. So those are 2 points that I wanted to add to the discussion, especially if we're talking about the scope of services that are required and having that in a centralized location.
All right,
Thank
thank you, Ms. Weber. Commissioner Barain?
Just briefly, thank you very much, Ellen, for those comments. I wanted to make sure that we didn't get off track on vocabulary. And I will apologize if we use the words case management imprecisely. One of the things that we have done and are continuing to do research on, but haven't completed our research, is what is truly a behavioral health navigator function. So there are states like California, like Colorado, like Washington, that really literally utilize that title. And the purpose of those roles, in fact, there are degree programs and training programs and certification programs, particularly in Colorado, but also it is again, we're working through the details, but in California, there's a university that actually has a certification program in being a navigator. And so that navigation function sits outside of any particular insurance company or a particular program, although they may be hired, and they are often hired into an organization like the organizations we've described, and their specific role is to help that person and their family to navigate the system. And that may include helping them to understand payment options that are available to them either through government programs or through their private insurance. And so I just want to be clear that when the MIA is perhaps, and I'll take the blame for this in that wordsmithing, is using the word case management, we really are referring to that navigator. And that's something that an insurance company may provide. There are external organizations that, for example, Care First, I saw on LinkedIn this weekend, has announced its partnership with an external navigation service that specifically helps connect people into mental health care, or it can sit within the provider world. You see those. So our research is continuing now at government levels and in education programs to see, how this navigation function is happening in other states. And that's, I will say, part of our research that isn't complete. Van Dorsey, who's our principal counsel, who's here today, has been working on this, and Joy Hatchett, who was unable to join today, who's the head of our CEAU unit, is also working, with Van's team to find out at the state level, other states, what they are doing in this regard specifically.
All right, thank you, Commissioner Barain. Mr. Askey.
Hello, good morning, everyone. So thanks. I just wanted to just mention a new initiative that we have that might could give some idea of reference in reference to a care coordination. So of course, with 2-in-1, our role is that to identify particular resources and make the connection to those services across the state. We've recently partnered with Behavioral Health Administration, in which we are providing care coordination for individuals within the emergency room across the state. So we're working with hospitals now for individuals who may be overstayed seeking mental health services. So some of the things that we've done now with this particular care coordination program is that we're doing statewide training with hospitals. We've created technology that can be used with ourselves in the hospitals that is interoperable, but we're all utilizing the same technology to track individual referrals, access to services, and gaps in the system. But also I think part of that is the benefit of it is, again, is the navigation, but also the connection and the training by both the institutions, by 2-in-1, but also the hospitals about, their workflow, what some of their needs are. And so that's, sort of another type of care coordination that we're currently providing for INR services, but specifically focused around individuals who are stuck within the emergency room for behavioral health services. So that is a service but it's only right now for the emergency room departments for folks that are across the state. So so that could serve as sort of an example of some of the things that's going on now.
Thank you. Any other comments?
Corey, could I, sorry,
Of-
not fast
of
enough on
course.
my hand.
It's
I just wanted to ask Quentin, do the folks in 211 ever support looking into insurance payment options for the behavioral health services, or are they really just dealing with getting the services to the people, and not the payment part?
It could be or the initial part is getting the service and the information depending upon the eligibility of the individual. If there are questions related to eligibility and cost, then the 211 call centers will help support that individual with whether there's research or warm handoffs to the entity. But it really depends on the individual who's calling and their ability to identify that information. But each call specialist is trained to do the research and identify information that is most helpful for the person that's calling. We try to put a lot of that information, eligibility requirement information on our site that's connected to those services. But the initial is providing the information. If there's some additional support needed, that call specialist will help to support that individual doing the research.
Okay, may I follow up, Corey, really quickly?
Of course.
And then, so I guess this is actually probably for Mary or the commissioner. In your research about current resources, did you find that most of the carriers had a navigation program like this, or was it sort of hit or miss?
So I think, and I'll let Mary finish up as well. It seems to me that most carriers have a traditional case management function that helps those patients who seek it out to find a provider if they're having difficulty doing that. So companies do have that as a resource. Now, that means the individual has to be aware of the resource. It means they have to reach out, and it means that they're already insured. And so they're working through their insurance company to try to find what they need. I think where it is used the most are people who need more specialized care or who need inpatient care and are struggling to find a bed or struggling to find the right kind of therapist for their particular condition. And I think that's where companies can offer and do offer that sort of navigation service within the scope of their coverage. If you are outside, remember, private insurance is 17% of the market.
Yeah.
Okay. So for the other 83% of people, there are a variety of different kinds of navigation services that can exist. So within the Medicaid program, there are navigational systems that can exist. Within private employers, and I think Dan and his group may be able to speak to this, it really depends on what the private insurer has come up with. So there's an organization that we're looking into. We haven't done a lot of research on it yet. It's called, I think, Quant. It's out of Pennsylvania. There are several other organizations that are offering this service to self-funded plans to help get people connected into care within the coverage that is provided by that self-funded plan. And I am not aware of really good services in that regard for, say, Medicare programs. So the answer is that there are pieces of all of this that are being done for people who are already in programs, and outside of programs, and Mary has worked with this data much more than I have, but I think that there may only be literally one or two organizations who will help the patient understand, will hold their hand through the coverage process the way they might hold their hand through finding a therapist. So what Mr. Askew was describing, somebody who's eligible for something, it is very helpful, and it's very important for people to understand what they may be eligible for in terms of government assisted services. But outside of government assisted services, if they have private health insurance, 211, as I understand it, is not currently set up to help somebody work with their insurer to get coverage when they find the care that they really need. That doesn't mean they couldn't expand, but I don't believe they're set up to do that right now.
Thank you.
All right, thank you. Ms. Rivkin?
Just had to get off mute, sorry. Just one thing I just wanted to at least tell you, Commissioner, something that I think needs to be explained based on your comments. While it's true that only 17% of Marylanders have fully insured coverage, so, at least for Care First, and I will make the assumption that if we're doing it, most every other carrier is, that number on your back of your card applies to anybody. It's not something we're just doing for the fully insured marketplace. We're doing it for our entire book of business. So the fact that we have the ability to do care coordination, have somebody call the back of their card to say, hey, I can't get an appointment. And we try to work with them to get in network. And if they need care coordination, we work on that as well. That applies to every member, regardless of what type of insurance they have. So I just wanted to make that clarification. Thank you.
Thank you. Mary?
I wanted to say that, most of you are aware that I was in life and health complaints for a very long time. And very often, once people get to their carrier's care coordination team, especially if it's dedicated to behavioral health, they tend to be very happy with that. But sometimes there can be missteps in trying to get connected there. And it depends on the carrier, and even within carriers, it depends on how well trained a particular CSR is when someone calls in. And so we thought that one benefit of a statewide program is someone who has the list of numbers to connect someone directly and do a warm handoff to their carrier's care coordination and follow up to make sure that they got there and that they got the care.
Thank you, Mary. Neil?
Yeah, I just, Mr. Askew mentioned warm handoffs as well. I was just curious if 211 had those numbers in-house so they can make those warm handoffs or no?
Regarding particular health entities?
Yeah. And regarding, I'm sorry, the carriers themselves. So Ms. Quay just said that, when people don't have the right numbers, they're not so happy. But if you're making warm handoffs, I'm just wondering if you have the right numbers. I want to make sure you have them if you don't.
So, we have information that's probably in our database, and of course, folks use that information outside of the database. But the information is only as good as we have. I can't speak specifically, if we have I'm sure we have probably a good amount. But one of the things that we always try to do is that, whatever additional data that's out there, whether it's resource data banks or numbers, we have that information, we can get it in. But we do have a data bank of, numbers, but again, I'm not sure exactly to what extent. But we always look to, again, to make those relationships and partner to try to make sure that the database is robust. But even again, if it's something that we can't find through the database system, then the navigators are pretty, pretty great with looking at other means, whether it's other sources, whether it's the internet, or contact the entities directly. They will take those extra steps.
All right, thank you. All right. Any other questions or discussions or comments? Ms. Ann?
Thanks, Corey. I just want to say, I think it is important that we're using the right kind of language, that CHAP as proposed is not a clinical function. It is about helping people use their insurance, using what they either pay for in the private market or what they're eligible for in the public market. And I guess to the question that really is, it was in the kind of where the email ended off, and I think, Mary, that's where you ended up is, is there a need for the service? And I think the advocates here, don't want to speak for anybody, but I think we're here because we supported the bill because we think there is a need for the service. And Delegate Cullison, heard you as well. I am very interested in any of the especially, any of the insurance carriers or others who are on here, if they agree that there's a need for this function.
Thank you, Anne. Deb?
As I'm listening to this conversation, because I think this is going to take multiple meetings for us to figure out the answer to Anne's question, because there are so many different resources that are very valuable. Whether or not there is one place that this can be housed and whether it will actually do what we need it to do, because I think there's a lot of complexity in this system, what we're describing, and whether or not the state has enough money to actually implement something like this, I think it's going to take some time for us to figure out. But something that just occurred to me that I would like to throw out to the group as a good first step, that maybe we can get the ball moving in the right direction, is we just spoke about how most carriers, if not all, have resources to help individuals get appointments or help with that care coordination, and that before we figure out a way to do a warm handoff or what's the best approach, could there be a possibility that we brainstorm different entities that could create a list? So probably I'm thinking the Insurance Administration, the Department of Health, HEAU, the Exchange, maybe some of the advocacy groups that has every carrier listed with their phone numbers right there, that anyone who is trying to get help can say, oh, I just contacted MIA because I can't get an appointment. And there's a list that says care first, call this number. Aetna, call this number. Or maybe to my understanding, we have 3 different ways that people can reach us. It's email, phone call, and the back of the card, and also through the portal itself, our member portal. So you list those things. So there are a number of opportunities wherever you try to turn to get help. You have those resources right there. And I'm just throwing that out as a good first step. So everyone will have that opportunity to get all the numbers from all the MCOs, carriers, et cetera, et cetera.
Thank you, Deb. Quentin?
I just wanted to get back on Deborah said, what Neil had asked, is that, even if it's a way that we could serve as that central repository just of information, because our site where we could, just host, whether there is a list or a resource page of all the numbers. I mean, we've done that for the Department of Aging. We've done that for the Department of Corrections, where we just created a particular page and it hosts that particular information. And we have the folks that could keep it updated once we have it. And so again, if there's just a one page that folks can go to, whether it's 211 to click, get all the numbers they need, that's also, I think, a valuable resource for folks as well.
All right, thank you. Ella?
Thanks very much. I mean, again, I think that we all agree that having compilations of lists are critically important. I think the vision of CHAP, though, is also to address what we all know is the inability of many people to navigate that by themselves. If people could figure it out by having a list of numbers, they would find the list of numbers. But we all know that individuals who are in a crisis with a mental health or substance use disorder problem, or a family member who has that, it's very often not enough to have a list of numbers or the place to call. You need the direct assistance and the support. And I think others on the call have already identified that. And I think Commissioner Bahrain, you identified that as one of the kinds of benefits of having a navigator. So no question, it's a first step, but it is only a first step. And if it doesn't in any way suggest that these other very direct supports by people with lived experience that have an equity focus are critically important. And so those are the other components that this proposal put forward.
Thank you, Ellen. Neil?
I just wanted to echo what Quentin said. That's exactly what I was thinking is, 211 could serve as a really great location for those numbers. But then beyond that, Ms. Quay listed a tremendous amount of county resources that exist. And I think that might be a good place for all those numbers as well.
Thank you. Anne?
I don't disagree with any of that. I just don't think that that should be used as a way to, we don't need to have that. I don't think it's an either or, right? I think that that's a great idea. Let's have as many, directories as possible. But that does not, I think, advance us in terms of, do we need this service or not?
Thank you, Anne. Delegate Collison?
Thank you, Corey. So, I've already mentioned that I'm really interested in learning more about the Navigator programs in other states. So I am interested in seeing, like I said, where it sits and whose responsibility it is. But I guess I have to ask, and if this is appropriate, I want to go back to Ellen. It's why would a person who's sort of struggling with, not being able to find something, know to go to the CHAP program differently from 211 or to their insurance company so it's not clear to me, that this isn't just one more, entity that people would have to have information about and education about, so I'll stop there. And just, if you can help me understand what your vision of that.
Sure, very happy to. And it's a very important question. I think one of the reasons we have developed the program as a hub and spoke model is for that very purpose. The spokes are entities that exist in all the 8 regions of the state based on the Navigator entity regions. And so that is sort of an entity that is actually on the ground, known to the community because it's a non-governmental organization that exists already in the community and already has connections, one would expect, to the Navigator entity, to county health activities, as well as knows and the crisis response entity. So those entities would work in collaboration and know that it is the CHAP spoke that is the entity that is there to figure out and assist with insurance-based issues. So it has that distinct role. It would publicize that distinct role, and it would work in collaboration with its partners in its region to serve that need. No question, it has to be publicized, but it is going to also be able to reach individuals because it's working in partnership with other local regional entities that are all focusing on, in some part, this insurance component, whether it's public insurance, private insurance, Medicare, or other payer systems. And again, this last point, I keep coming back to it. The fact that it is going to be, there are going to be individuals with lived experience who are part of these entities that are delivering the service couldn't be more important, because it is through that one-on-one contact, that trusted individual who knows that someone else who has had experience in accessing care for a mental health or substance use problem is on the other side of the table, on the other side of the call, and is there and understands that person's experience. We believe it is that some of the stigma that's still associated very much with identifying and coming forward with a problem and understanding what it takes to get to care and get your insurance problem resolved makes all the difference in the world.
Again, Corey, if I could just follow up. So Ellen, it just sounds to me like you're primarily focused on insurance issues. And I think that's the function of MIA. And so for me, what I'm looking for is the coordination and access to all these tremendous resources that we have. And talking about the trusted individuals at the local level, we heard from Mary about a couple of organizations just like that people might not know about, like Voices of Hope, that people might not know about, but they could certainly learn about through 211. So, I mean, I think, I'm trying to, I started off this whole, my discussion about this at the last meeting is to maximize the resources that we have and perhaps better coordinate them so that there's greater access. Overall, it's not just, if there are insurance issues, let's deal with those with MIA. Okay, I'll stop talking now. Thank you.
Okay.
And if I could just respond, please. There's no question that there are government entities that have this job, but MIA has a discrete role. It resolves if somebody has an insurance complaint, they can file a complaint with the Maryland Insurance Administration. The MIA does education as well, but it is not their job to do the day-to-day helping a single individual navigate through their insurance coverage and resolve a barrier that is put in that process of accessing the right provider, making sure that that provider takes the insurance if they have the opportunity to go out of network to do that. If there is a parity violation, right? If there is a problem that it just appears that there's a barrier, a mental health problem that this individual hasn't experienced with regard to a medical problem, that's a parity problem that individuals within the CHAP program will be trained to identify and be able to pursue those problems. And they could pursue that in a number of ways. They may pursue them by providing direct assistance to that client to file an appeal, or in addition to that, though, they may also learn that there are 4 or 5 individuals who are experiencing this same problem. They're identifying a trend.
So
and they can
Ellen,
resolve
I'm
that
sorry, I don't mean to be rude, but we have 15 minutes. I want to say one small thing, and then we want to hear from Senator Augustine, and then we want to invite interested parties to make comments in the time that we have left. Just 2 quick thoughts. First of all, the CEAU unit, you are correct. We are not lawyers in the sense that we specifically represent. However, the MIA does have not just an education unit, but an advocacy unit. And the things that you are describing in terms of, holding the hands of consumers as they navigate through is something that we do on a daily basis, and particularly where healthcare and appeals and grievances are concerned. And that's a function that could frankly be something we can talk about expanding within our CEAU unit. And it is our job actually to identify mental health parity violations and to look for those violations. So I think that the MIA does have a role in that regard, but again, with respect only to the private insurance market. The other thing that I was going to say is that as we continue our research on what individual states are doing and how they're tackling this problem, for example, the peer function that you've described, Colorado, for example, has a very thorough certification program that individuals go through in order to qualify for that navigation function, as people are helping others through their shared their life experience. So those are things that we are looking at what other states are doing in that regard. We'll provide that to the working group. I think that one of the things that perhaps the working group also needs to focus on is there seems to be a consensus around the notion that having a coordination function is important. But the other question is that to be a pointer? So does that coordination function mean there is a number that everybody knows to go to, and then that organization, that coordinator points you into those other areas and would take you to those individual resources and those numbers, et cetera. And then the handoff to that other underlying organization would be where the individual is navigated, where that navigator function sits. So, once you guys give us some direction, we'll also know where we can focus our research. And with that, I want to give Senator Augustine the opportunity to speak before we hear from interested parties.
Thank you, Commissioner. I really do appreciate it. And I just want to circle all the way back to this, which is that these are all tremendous resources, but we come to this piece of legislation because the overall system is failing the people of the state of Maryland with regard to accessing their services. And that I still will stand on that. Maybe fail is a little too strong. Let me back off of fail. Let's say that we know that there are problems and that people are having trouble, that a significant number of folks have problems accessing the care that they need. And we want better behavioral health outcomes for the state. I thought that Mary's memo was a very good. I thank her for the memo. I thank you for the report and the work that was done on this. I think at the end of her memo, she indicated that there is a need. That's what I read. I don't know, maybe because that's, what I thought I read something like that on there. And Commissioner, I also just have to say though, too, to you that I expressed concern that this was going to lead down a path, and I said it, of where we are right now. And I'm trying to hold myself back a little bit. I hope that we will not allow, as I suggested my worry before, that this would then slow down the other things. Tremendous progress. Thank you so much. I love the idea of the work that you guys are putting into it, looking at other states, figuring out how to work on this. I hope that we do not get bogged down on this. I'm concerned, but I thank you so much.
Thank you, Senator Augustine. So do we have any comments from our attendees?
Just let us know in the chat if you do.
There are a couple people on the attendee list that look like they've raised a hand. Look, Mr. Stewart, for example.
Mr. Stewart, you should be able to.
It just took me a second to figure out how to get in technically. I've got to say, I am the program director at AHEC West in Western Maryland in Cumberland. I run the health insurance connector entity for Allegheny, Garrett, and Washington counties. I do consumer assistance every single day and have done it for years now. And I strongly support this CHAP program, and I clearly see the need. I agree with what the senator just said. It is not what we have in existence is definitely not enough. Lists are good for my navigators to have, but the reason people come to my staff is they get connected to a human being that they trust. And I just can't agree. It's like a bowl of noodles, right? If you throw a bowl of noodles at people and you say, pick one noodle out that's got the answer for you, that's what consumers face now. They don't know what noodle to pick up. And so the existing system does not work. I know because I get calls, my staff get calls every single day for people who have problems accessing care. Now, we're really good at signing people up for health insurance. That's what we do. But when it comes particularly to behavioral health issues and substance use disorders, it's incredibly complicated. I don't have the bandwidth, and I'm well funded for my people to pick that piece up, and to have an ally in the field like this program is, in my opinion, essential. I refer to people to the MIA and the HEAU all the time. It's not enough.
Thank you, Mr. Stewart. Anyone else? Going once, going twice. So discussing our next steps. What do you all suggest the next steps should be?
And just reminding everybody, that, to the extent that there are concrete ideas like, Deb Rivkin's ideas that we can take on the side and certainly put those into action. And, the MIA can help coordinate with Mr. Askew and others about how to do that. But I think to Senator Augustine's point, our desire is not to lose track of the purpose, which is to say, is to look at the CHAP bill and can we get consensus around the need for the program, if there's a need for a program or a function, what is that need? What are those functions? And, focusing on, I think, whether this working group is going to be able to make recommendations coming out of the working group about, what are the programmatic needs in this space. So just wanted to make sure that we stay really clearly focused on that. Corey, I'll just turn it back to you.
All right, thank you, Commissioner. Senator Augustine.
Just want to echo what Commissioner Bahrain just said. And so I think that going back to the bill, which is what we had talked about, and the areas that folks had their concerns, we kind of went through that process a little bit, but we didn't continue with that discussion. I hope that we will be able to do that, to see where we can iron things out, fix things, figure out, that would be my hope, in keeping with what the commissioner just said.
Thank you, Senator. Delegate Collison.
Thank you, Corey. I'm just wondering, Commissioner, and maybe Mary and your team, will we have some information about some other states before we meet again in terms of how they do it?
Yes, and that may be what Mr. Dorsey it will be addressing as well, although I don't know. But yes, we are working through as many states as we can find that have some form of, whether it's a centralized state level function, and then where it sits. Like New York has a similar function, but that sits within the Department of Health in the state of New York. It's not a separate, or funded organization. They do have a hub spoke model and they do fund underlying organizations, but that entire structure ultimately sits within the state government, and then they fund and grant and oversee. So we're working our way through the various states. And Van, do you want to speak to that?
Thanks.
Yes, thank you, Commissioner. You sort of stole my thunder a little bit. I mean, one of the things I wanted to say was, I think before we get into the structure of what this should look like, I think it probably makes sense to, to find out what the what is. And, and Doug Collison has talked about that with regard to, the central coordination piece. And I think the what of that is what do we want that central coordination to be? If there is consensus that we think there should be central coordination, and then the second part of that is what should it be with regard to the structure. That there's the hub and spoke model of the bill, but then there's as the commissioner said, there's the hub and spoke model that we've seen in other states, and New York is the one I've looked at the most, where there is a state government agency that is in charge of the hub and spoke, and it is responsible for doling out grants, and you see the flow from the work chart that they have. So that that makes sense to me. But but before we get to the structure of it, I think we really want to know what the what is. I think.
All right, thank you, Ben. Any other suggestions, comments, Helen?
Yeah, I mean, I agree that again, what our primary goal is to work out differences based on the legislation. And as you know, the legislation had a comprehensive set of functions that it identified, and those comprehensive set of functions are based on a federal law that created the federal funding under the ACA for consumer assistance services, and it is a full-blown program that goes from soup to nuts, and that's the proposal that is in SB 460. And I work at the Legal Action Center. We are part of the New York CHAP program. And there's no question there is a state entity that doles out the money. But bottom line is, those activities and services are provided by the Consumer Services Society with spokes in the community and with specialty organizations that provide assistance. And Legal Action Center is one of those organizations, and it provides assistance on the Parity Act, and it also does policy advocacy. And that is a model that is the soup to nuts model. It provides navigation services through spokes. It provides client representation. And the lessons that have been learned from CHAMP are that you need that full continuum. So in terms of centralization is a hub, but the services have to be, it seems to us, sort of decentralized in order to achieve what David Stewart has identified, that trusted individual who knows the community resources. And so saying centralized means one thing in my mind. What we're talking about is a truly disseminated entity that really does meet the needs of the community, recognizing that Maryland has many communities and is very different.
Okay, thank you, Alan. And Anne posted a few comments in the chat. Can we get someone with New York's program to speak to this group, or perhaps send some info to us? So I think that's part of our homework of doing research.
Well, and I think we had a little mini version of that just now too.
Okay. Okay. Neil?
Thanks. I just wanted to mention that, in our first meeting, we talked about what our goals were as this group, trying to sort out the issues of the legislation. And in that meeting, we said, okay, well, what else is happening around the state and around other states? And I think the MIA has done a phenomenal job putting this information together, and will be providing more information about Colorado, New York, and other states. And so I think we're really on the right track here. And I just want to say I appreciate everybody's work. I know that we've talked more about coordination and navigation today, but there are, fundamental disagreements in terms of what else this entity, whether centralized or decentralized, should be. And that's, I think, what these next meetings are really for. But I think just in terms of process, the purpose of today's meeting was to talk about what else is out there and how that fits into functions that we all fundamentally agree on, not so much disagree on. So just wanted to put that out there and thank the MIA for putting it all together.
All right, thank you, Neil. So the MIA, we proposed 4 upcoming meetings: September 9th, September 30th, October 18th, and November 18th. So we certainly have our homework to do. Does anyone from the MIA have any closing remarks?
I think that what the MIA will commit to is taking this information back, trying to synthesize it, and then sending a sort of a note out to folks of where we think we landed, so that if we get it wrong, you can give us feedback about that. I also think that one of the things that we will continue and be able to do interim reporting on more detail about what some of the states are doing. But I think what we want to try to work toward is do we have consensus about whether their needs? Let's start with the idea of whether we have consensus. And this sort of to pose maybe for our like a vote that's on September 9th. But do we have consensus that we do need to have this centralized coordinating body to begin with? And what is it coordinating? And then I think, I don't think anybody would disagree that you then also need to have the actual navigation functions happening, at what Ms. Weber calls the spoke level. So within those organizations. So is that a need, and is that a viable structure, so that you fund a coordinator who becomes the one-stop shop, where people then get connected to wherever within their individual community they're going to meet that person who's going to guide them. So,
Commissioner,
yeah.
I'm just I didn't think that's what we said at the last meeting.
Okay.
If you recall, we were going to do this exercise, which I'm very grateful for. It's fantastic, learning a lot, but that it would not stop us from going through the bill itself. Now so I like who you're saying a vote. Who would that be? I mean, I don't see where that's even a worthwhile discussion to have.
Okay.
I'm good with us using this as a base of understanding, which is outstanding. Like we need to learn more and more and more. I'm good with that. This is great, but it does not change, as I said in the previous ones, that the Senate of Maryland, passed a piece of legislation that was sent over to the House. There were some conversations about what that piece of legislation was. There were issues, people had concerns. The discussion with Chair Pena-Melnick was, during the interim, work on that, because there was a sense that there wasn't, a working through of the legislation itself. I don't want us to get off track of meeting what the charge of Chair Pena-Melnick, would I support it very much, as far as, the bill itself. If folks are just fundamentally against the bill, which is okay, that's okay, but that was not the charge of this entity. They can express that. There still was, the discussion was, there were specific things that were brought up that were of concern. How do we look at those things? How do we address those things? I hope we don't get off track of that. I've just got to reiterate that.
Well, and obviously I want to be very respectful of you, Senator, and, your understanding of what the working group is and what it's intended to do. So what I'm hearing you say is that we should start from the proposition that the program exists. And then what are the elements of the program that people might disagree with? I just want to make sure that we get it right, because that's where we started last time. But then the working group said, well, do we even need a program? And, that.
I didn't hear that either in the conversation. What I heard was, which I was supportive of, what are the resources that are already out there to us to have a baseline to understand? And I think that's what Delegate Cullison had mentioned. She wanted to better understand what all was out there, what's happening. It wasn't, it did not, and for me, I thought that was educational. We better understand everything that's out there. I didn't hear a specific, no, we're just, we're not doing this. And that these are, we're just, so I just didn't, that was never my sense, but I feel it here. I didn't hear that at the last meeting. I didn't come away from that. In fact, Commissioner, I asked that this process not derail the other, if you recall. I was hoping that we would have those meetings continue with regard to the legislation itself, which right now, I'm just hearing something a little, and so that's just, I just hope that we can still do that as the charge of this, using everything, which I'm all good with. This background was fantastic, learning from others and everything else, but that we did have a piece, a concept that was, passed by the Senate and sent over to the House, and that we are looking at that piece, and we, that's all that I'm saying.
Well, we are happy to coordinate this in any way the working group wants to coordinate it. So we can, in our next meeting, report back on what we're hearing the other states are doing. But I think to Van Dorsey's point, if what you want us to do is then just lead through in the next meetings, okay, the next, yes, there is a program. Now, what is the structure of that program legally? So, and then what is it? Is it a semi-state agency? What's it accountability? What is it subject to? And then, what is the scope of its services? So what is it going to cover?
But for me, again, there were real concerns that people had, and I think that we should hear the real concerns. Like there were in the meetings that we had that people had about jurisdiction. I mean, things that I hope we would talk about, about those kinds of things. But I'm just saying that we do it and just kind of, not saying that we get to a full agreement at the end, but that we do go through and say, well, okay, yeah, this is why we held concerns about jurisdiction on a particular part or whatever. And how is it, because we did make some, we worked on this with folks, obviously, to try to address some concerns and issues. That's all that I'm trying to say. I'm hoping that we can do as far as addressing that. And I see, I don't know, are you chair, vice chair? What are you, Delegate Cullison?
No, I am the chair of the insurance subcommittee.
That's
So
right.
why
That's what I say. So Chair Cullison, obviously,
right.
we'll hear from you.
So yeah, and I think, I guess Senator, my committee had a lot of questions about the need for this kind of comprehensive program, because there were, resources that were being untapped or uncoordinated. And so for us, I think what we, and I think that's what Chair Pena-Melnick was looking at when she asked us to look at this. It wasn't specifically the language of the bill, but what kind of program is needed to address the issues that were identified by the bill, or the need for the bill. So I think that's what I think we just did with, looking at the current resources as it that are out there, and understanding that there isn't really, and this is something that I felt for my 12 years in the legislature, there isn't any coordination of these services, and there's no other than 211, which has the largest database in the state by my estimation, no place that an individual can go to say, I need to find a pediatric psychologist and I can't find it. So, where do I go? And I think, and for me, getting that coordination of services, and I think a lot of the on the ground stuff does already exist. People just aren't connected to it. I heard Mr. Stewart talk, it seems to me his organization is doing a lot of the spoke part of the bill. It may not be identified that way, but at least it's part of it. And so how do we incorporate that into a larger, and I've said right from the beginning of this meeting, I recognize the need for more coordination among, and particularly among existing resources.
And that outreach is actually a part of the bill, Chair Cullison. I mean, it's one of the things that's actually outlined as being one of the things that it needs to do. Again, just sort of understanding, starting from a place, a fundamental place of how are we doing in this space for the people of the state of Maryland. And maybe we do need to step offline and have a conversation around that, because that's really where I'm coming from on this. If we've got a way to, to make this better, that's what I'm hopeful that's what this is for. And I just, so my conversations, like let's accomplish both, because I came away from my conversations with Chair Pena-Melnick a little bit different when she and I talked this thing through, but I think we can do both. And I think that's what's been happening here. Of course, all I'm asking, Chair Cullison, is that we not look at the actual legislation itself. I'm all for, doing let's try to do both then, right? We're looking at this, want to see what other states are doing and everything else. But we did bring something forward. There were specific questions that were asked. In addition to the larger question that you're talking about, there were also some specific ones that, I was hopeful we would be able to deal with. So
okay. Happy to do that, Senator. Thanks.
So we'll make the commitment, Mr. Stewart, I'm going to invite you to comment at the next meeting, just to be respectful of people's time. But what we will commit to do at the MIA is we will try to synthesize what happened today and send that report out so people have that in the interim, can comment on it, make sure that we got it correct. We will be prepared to report in more detail on what other states are doing, but we will also make it a 90-minute meeting perhaps. And that way, and we will begin to go through in each of these meetings, those specific other areas of concern that we identified, you know, in our opening invitation, so that, to the senator's point, even if there isn't complete consensus on, you know, every item, let's see where we wind up at the end of the working group. But at least we will have done the work of getting into the meat of issues that were specific to the program. And we won't have left any of that unturned, because, to the senator's point, it doesn't want to get, and I appreciate this, caught up in every meeting discussing the need for the program.
Right.
Okay. So, Corey?
All right, well, thank you, everyone. Our next meeting tentatively will be September 9th at 11 o'clock. We will send out a notice and email just to remind everyone, and obviously the research and work that we've done at the MIA. So you all know how to reach me. Until next time, take care.
Thank you. Bye.